of porosity, and what it gives a calculated score. It gives an overall score which is calculated after transforming the 3D structure and projecting into a 2D plane. So this score is calculated only at the lumbar vertebra. So the guidelines say that you have to do trabecular bone score only at the lumbar vertebra, and there are reference range, but this is not validated by WHO as of today. But for all practical and academic purposes, more than 1.35 we take it as normal, and less than 1.2 we take as a serious degeneration. And there have been multiple studies in type 2 diabetes. One of these studies where you can see that the comparison of bone mineral density versus trabecular bone score in the same patient, you see that the trabecular bone score is 2.6, which scores on higher when you compare it with a BMD. So what are the correlates of trabecular bone score? So trabecular bone score would negatively correlate with BMI, waist circumference, insulin resistance, fat mass, and HbA1c. So considering all these risk factors also as one of the aggravators for metabolic syndrome, and it positively correlates only with lumbar spine BMD, and that is why trabecular bone score is done only for the lumbar spine. We promote a lot of weight loss now in diabetes, and at the same time we also have spontaneous weight loss in diabetes, but remember that with weight loss you also have bone loss, and there have been studies that if you increase weight loss, you have increased fragility of the bones. At the same time, patients who have been on GLP-1 receptor agonists, patients who have undergone bariatric surgeries, they are also prone to osteopenia and osteoporosis, and that is why when we try to promote weight loss, we need to also promote at the same time resistance exercises along with the weight loss. So that is one thing which we need to keep in mind. Also, we need to have quite a good knowledge on effect of diabetes treatment on skeletal health. So if you look for neutral or positive effects, then you have metformin, DPP-4 inhibitors, and GLP-1 receptor agonist. If you see the negative effects, you have with thiazolidinediones, sulfonylureas, and insulin. And then we need to have other consideration, like you need to have HbA1c target to the best possible control. At the same time, you need to prevent hypoglycemia related falls, because I said frequent fall could be one of the other risk factor for osteoporotic fracture. Do we have serum markers to diagnose osteoporosis? As of today, no. But we do have serum markers now to study the efficacy of the drugs and for follow-up of a patient who is on anti-osteoporotic treatment. But to diagnose skeletal fragility, we still do not have any serum biomarkers. So how do we approach a type 2 diabetes patient? So either if the patient presents to you with fragility fracture, or the patient presents to you with a clinical risk factor for fracture, you need to calculate their BMD, do a thoracolumbar X-ray, especially if you find your patient having a reduction in the height, and then you can use fracture risk calculators like FRAX, which we have online availability. Look for the T-score. If the T-score is less than minus 0.2, 0.0, then that patient is at a higher risk. And if the patient is having less than minus 2.0, then you have to go for 1 or 2 yearly assessment. I'll come to some specific risk factors for diabetes, but in general, if you have to go for approach, you have to go for lifestyle interventions with medical nutrition therapy and exercise, which includes a moderate weight loss. But at the same time, this weight loss should be associated with intense walking and weight-bearing exercise. We need to limit alcohol and stop smoking. For treating type 2 diabetes patients, try to prefer metformin, sulfonylurea, DPP-4 inhibitor, and GLP-1 receptor agonist wherever required, and avoid thiazolidinediones in patients who are at risk for osteoporotic fracture. We need to check and treat blood pressure, vision, neuropathy. This has to be a continuous assessment. And if we really find out that there is a need to treat osteoporosis, then we need to prefer bisphosphonates in majority of the patients, and we need to keep monitoring these patients. Few important tips that we need to keep in mind for management. We need to identify diabetes specific risk factors. So type 2 diabetes, if you have a duration more than 5 years, presence of micro and macrovascular complications, persistent HbA1c more than 8%, patients at severe hypoglycemic risk, and patients on high dose of insulin, thiazolidinediones, and canagliflozin. These are the major patients of type 2 diabetes who are at high risk of osteoporosis. And when you consider anti-osteoporotic treatment, you need to give it to all patients who present to you with either a fragility fracture or a BMD T-score less than -2.0 on a DEXA scan. We need to consider fracture risk above country-specific thresholds. And for type 2 diabetes, we have different calculators like FREX Plus or Q fracture score. On the FRAX, again, you have some modifications that you need to do for diabetes because FRAX does not account for diabetes as a risk factor. So what are recommendations? You reduce the T-score by 0.5. So if a patient has 1.5 on DEXA score, for that same diabetic patient, you will put it as 2. Or you increase the age by 10 years. So if you have a patient of 50 years, when you enter on DEXA score, the FRAX calculator, you put it at 60 years. Or you select rheumatoid arthritis as a comorbidity, or you include trabecular bone score adjustments. So this is the way that you can actually find out what is the risk for your patients. Then which anti-osteoporotic pharmacotherapy? So if you have a hip fracture, preferably you go for IV zoledronate or injection denosumab. For vertebral fractures, we have found that teriparatide scores over IV zoledronate and denosumab. And for maintenance therapy, you can use oral bisphosphonates. And for those patients who have no fractures, you can use either oral or IV bisphosphonates to reduce the fracture risk. Calcitonin has no role except for some pain relief in the fractures. Certain precautions that you need to keep in all your patients: select glucose-lowering medications with neutral or beneficial effects on the skeleton. Maintain adequate vitamin D, because this is something which we can practically do in all our patients. And remember, if your patient is obese and if your patient has malabsorption or your patient has gastroparesis, then probably these patients might require a higher dose of vitamin D than what is recommended. Also, we need to supplement adequate dietary doses of calcium for these patients. Ask them to maintain an active lifestyle with weight-bearing and balancing exercises. Limit alcohol, quit smoking, and keep on assessing the patient's false risk and improve their physical function. This is very, very important that we need to holistically approach all our patients. So for skeletal fragility, as I say, the mechanism is still poorly understood, though the problem is increasing. So that is why I always say our knowledge can only be finite, while our ignorance must always be infinite. We need to keep researching on this aspect of diabetes and the risk on the bone health. And with that, I thank you all, and I'll be happy to take your questions.